Hi, this is Dr. Shurpaneni. I'll be discussing asthma and briefly also touching on allergies. If you have asthma, you may be experiencing coughing, shortness of breath, chest tightness, a chest wheeze. You should ask yourself, do you experience a cough at nighttime? Do you feel out of breath when performing activities like cleaning or going up the stairs, doing yard work? Does exercise like running, jogging make you feel short of breath, cause a coughing spell? Do you immediately react with a cough, chest tightness, or shortness of breath while outside in the cold, windy, dry, or wet weather conditions? Do you have a runny nose, itchy throat around pets or working around trees, flowers? Think pollen, ragweed. Do you also become short of breath while cleaning mattresses, bedding, upholstered furniture, carpet, curtains? Think dust mites. Asthma prevalence in US, based on statistics from 2018, shows it's prevalent among 20 million adults and 5 million children. Asthma can simply be defined as inflammation of your airways. This inflammation is usually triggered by either extrinsic or intrinsic factors. Extrinsic factors can be allergens such as ragweed, pollen, dust mites, dander, or intrinsic factors can include cold air that you inhale, smoke, viruses, infection. Next, we'll talk about extrinsic factors such as allergens, which affect a big proportion of our asthma patients in the US. Those cool nights and warm days are an ideal climate for pollen. Early morning joggers should experience a higher pollen count. If you live in the Midwest, in a city like Chicago, the Windy City, then you know windy, warm summers can almost guarantee you that you'll be experiencing a higher surge in pollen counts. Unfortunately, that doesn't mean we can escape our environment. Allergens thrive in a lot of different conditions. Spring, summer, fall tend to be the peak periods. Other types of allergens include pine trees, reeds, even chemicals while you're cleaning your pool like chlorine, tobacco smoke, smoke from campfires can be a source of your allergies. In fact, seasonal allergies is almost a misnomer. Patients can experience allergy flare-up from allergens all the way from January to December. If you look at the data, there's strong evidence of people reacting to allergens throughout the year. January is the time when winter allergies are still flaring up. Dust and mold allergens unfortunately affect people throughout the year. As we wind down from January into February, you start to notice pollen counts going up, probably to trees. And as we move into the spring season in late March or April, you have flowers blossoming, which also contribute to high pollen counts. In the early summer, May, and then mid and late summer, June, July, August, you start to see a transition from tree flowers to tree and grass contributing to pollen. You can see a peak of pollen counts from grass, especially in June. Then you start transitioning into mostly weed during July and August. In June, we're still seeing a spike in pollen from grass and start to notice pollen like rye, oat, Bermuda. Then we transition into July when we start noticing a spike in weed like pigweed, ragweed, etc., which can last into August. End of summer in August, can really be marked by decrease in pollen counts in August and an eventual rise in weed counts, especially through August, September, October, and November. Although levels tend to plateau close to end of October and November. The fall season can be especially harsh for patients who suffer from spores from mold, since mold spores can be at its peak during end of August and can worsen in the months of September and October. This is especially true for patients who live in warmer climates who may be affected by wind and rainfall. As we move into late November, unfortunately, pets become our main source of allergies. Although outdoor allergens are dying, pet dander, saliva, indoor mold can become a big source of allergens. You're looking at a picture of my dog, Whiskey, who is celebrating his 6th birthday this year. As we wind down our year into December, although outdoor allergens are at the bottom, unfortunately, there's one source of pollen, which happens to be mountain cedar, especially in the south, can lead to an allergy outbreak. The best way to think about intrinsic factors as a source of asthma would be to just simply exclude all allergens. Anything outside of allergens can be considered an intrinsic etiology for asthma, be it acid reflux, infections, postnasal drip, inhaled tobacco smoke, just viruses in general. The pathology behind asthma is pretty similar to both intrinsic and extrinsic types of asthma. Just understand that the inflammatory response is due to a process by our immune system where mast cells, basophils, are releasing chemicals like cytokines, interleukin 3, 4, 5, resulting in an inflammatory cascade. Following the inflammation cycle, our body signals B cells to produce IgE and antibodies that are specific to the allergens triggering our asthma. You notice that patients who have asthma, their serum levels of IgE tend to correlate to the severity of their asthma. So knowing that asthma, especially allergic asthma, could be an IgE-mediated process, patients may have IgE antibodies against allergens that they're exposed to. Doctors can target these IgE antibodies with medications like omalizumab or Xolair and Dupixent. These are monoclonal antibodies which target IgE-mediated antibodies. Over time, with uncontrolled asthma, patients will suffer from obstructive lung disease. In asthmatics, they struggle with bronchoconstriction and persistent inflammation resulting in mucus plugging and certainly difficulty with clearing air from their chest. Some terminology to understand. Asthma falls in a category of lung diseases called obstructive lung diseases, where patients struggle to exhale, there's airway resistance, and asthma shares some characteristics with other obstructive lung diseases like bronchiectasis, COPDs, as seen in smokers. The main differentiator to remember between asthma and COPD is that asthma does not affect the parenchyma of the lung. Asthma is predominantly localized to the airways and is mostly an inflammatory disease of the airways causing airway resistance. Airways in asthma patients can get constricted due to persistent inflammation due to allergen exposure, resulting in hypersecretion of mucus. It could be fibrosis, it could be hyperplasia of smooth muscles, congesting airways. So let's talk about testing. Initial testing may include pulmonary function tests, which includes spirometry, which is basically assessing for lung volumes. So when a person exhales, they're looking for capacity of airflow that you're exhaling in a certain amount of time. So usually measured as functional expiratory volume in 1 second, called FEV1. When you go through testing for asthma, a doctor might ask you to go through pulmonary function tests, where a technician may give you a machine called spirometer and place a mouthpiece in your mouth and have you blow into this tube and to measure values like forced vital capacity and also forced expiratory volume over 1, 2, 3 seconds. Some definitions. Forced vital capacity is basically the amount of lung volume that you can exhale after taking a full deep breath. And forced expiratory volume is basically a forced breath that's measuring the amount of air that you exhale over 1 second, correlating to FEV1. We have a predicted normal FEV1 based on a patient's race, height, and weight. So we take the measured value as a percentage of this normal predicted FEV1 and see where you fall in terms of your lung health. If your numbers are greater than 80%, you're generally in good shape. If your measured FEV1 is 80% or greater compared to the predicted FEV1 based on your characteristics, then you're doing pretty well. Otherwise, if your number falls below 80% but greater than 60%, then it implies mild disease. If the percentage is between 40 to 59%, then it implies moderate disease, and less than 40% is always consistent with severe obstructive lung disease. Next test I want to talk about is a peak flow meter, which is a handheld device you can keep with you all the time. It becomes really handy in predicting an impending asthma attack, very useful in children, which can be easily taught in terms of how to use it. A peak flow meter is a convenient way to test our ability to blow air out of our lungs. Generally speaking, this is going to be a number that we rely on to predict how a person is doing in terms of management of their asthma. An average peak reading could be between 400 and 700. Let's talk about how to use a peak flow meter. Number 1, try to put the marker on the peak flow meter at 0. Number 2, stand up, hold the peak flow meter in your hand, take a deep breath. Next, place the mouthpiece device in between your teeth, close your mouth, lips sealed, blow as hard as you can and as fast as you can. Record the value you see during this process. Repeat the process 2 more times and write the highest value. This should correlate to your baseline value when you're doing well. One of the tests we commonly utilize in a hospital setting or a clinic setting is a pulse ox that checks your oxygen saturation level, or O2 sats. In short, this value is extremely important in a patient who's an asthmatic to accurately assess their ongoing severity of asthma. If a patient's oxygen saturation is above 97%, then it's a reassuring sign of patient's lung condition and oxygenation capacity. Now, if the number starts trending down below 92%, then the patient is going into acute respiratory failure and will benefit from supplemental oxygen, either non-invasive via cannula, face mask, or invasive like mechanical ventilation. In clinical practice, we can order a test called nitric oxide test to correlate the level of inflammation that's going on in your airways to the levels of nitric oxide. Nitric oxide levels tend to be higher when there's an inflammatory response. So this device that checks for nitric oxide levels when high correlates to a high level of inflammation that's ongoing in your airways. I like to think of treatment of asthma in the form of rescue and maintenance. Rescue treatment primarily involves dilating our airways to allow for airflow to improve so a patient can inhale, exhale freely without struggling to breathe. Therefore, a patient can receive treatments like bronchodilators, which is a beta agonist called albuterol, and prednisone, which is a steroid to decrease inflammation in their airways. Other treatments under rescue include anticholinergics like ipratropium, which is also helpful to dilate the airways, and use of oxygen if needed, if a person's saturations are dropping, and mechanical ventilation when a person is in acute need of an airway support when they're not able to breathe on their own. Some of the mainstay of maintenance treatments in asthma control include inhalers that include ingredients like inhaled corticosteroids. You may have come across inhalers like Flovent, Qvar, and long-acting beta agonists like salmeterol, formoterol, and anticholinergics like tiotropium, which is Spiriva. Just keep in mind, you can only use a long-acting beta agonist along with an inhaled corticosteroid in asthma patients. Inhaled corticosteroids decrease inflammation in your airways, while long-acting beta agonists like salmeterol and tiotropium, which is an anticholinergic, usually help relax the smooth muscles in your airways so you can breathe better. One class of medications that are commonly prescribed with people who suffer from allergies and have symptoms like postnasal drip or a runny nose and suffer from chronic urticaria, they may benefit from a medication called Singular, which is a leukotriene inhibitor. To summarize, a doctor may consider starting you on inhaled corticosteroid due to your lack of asthma control for a maintenance purpose, but as the control gets worse, they may choose to add a next step up, which is a long-acting beta agonist like a salmeterol in combination with the inhaled corticosteroid. Only after that point, they can consider a leukotriene inhibitor. Let's take an example of a patient who has moderate persistent asthma. If they don't respond to inhaled corticosteroids for maintenance, we can consider adding a combo inhaler that has both inhaled corticosteroid and a long-acting beta agonist like Advair or Symbicort. Only thereafter, a third-line option like Montelukast, which is a leukotriene inhibitor, can be considered. Unfortunately, patients who have chronic persistent asthma due to allergies do not respond to traditional medications alone. They may benefit from monoclonal antibodies that are directed against the IgE antibodies. So some of the medications that can be tried are Xolair, Dupixent. These are usually given as shots every 2 to 4 weeks. The main risk with using IgE monoclonal antibody drugs is some patients develop anaphylactic reactions like hives, tongue swelling, chest wheeze, low blood pressures. Therefore, close monitoring of these patients is extremely important, and recognizing these symptoms right away is extremely important. Another drug that's worth mentioning is called Theophylline, which is a methylxanthine medication. It needs to be monitored closely due to its toxicity risk. At low concentrations, it can decrease inflammation, and at higher concentrations, it can improve bronchodilation. But the drug can interact with many other medications, making it difficult to manage, and it's kind of falling out of favor in clinical practice. Patients who are unfortunately disabled by hay fever, either due to seasonal allergens or year-round allergens, especially debilitated by symptoms like runny nose, stuffy nose, sneezing, itchy eyes, and are unable to cope with over-the-counter medications, they may benefit from immunotherapy or desensitization therapy, which can be done via subcutaneous shots or sublingual tablets. A typical desensitization treatment regimen could include shots you may receive once a week for 9 to 12 weeks, where they escalate the amount of allergen concentration that you're receiving on a weekly basis to eventually desensitize you from the allergen. The more specific allergens like pet dander and hair, tree pollen, grass pollen have been shown to be the most effective in terms of desensitization. Let's briefly talk about Asthma Action Plan and why it's important and how you can incorporate this into your treatment regimen. What you're seeing is an Asthma Action Plan, which helps patients organize their current symptoms into one of three buckets. The green bucket, which is basically shows that they're currently in baseline health. Yellow bucket or yellow zone is basically indicative of a person getting worse. And red zone is the danger zone when a person is actually experiencing an acute asthma attack. Green zone is indicative of a person who's actually well controlled with their asthma. From a symptomology standpoint, you're not experiencing any symptoms like cough, wheezing, chest tightness, shortness of breath during the day or night, and you're able to do usual activities. And from a peak flow standpoint, you're at least hitting 80% or more of your best peak flow measurement. Yellow zone correlates to a person who's experiencing coughing, wheezing, chest tightness, or shortness of breath, or waking up at night due to these symptoms. They can do some but not all usual activities. Or a peak flow measurement that's 50 to 79% of their best peak flow is consistent with the yellow zone. An initial step while managing your care in the yellow zone may include you're taking the albuterol inhaler, which is a short-acting beta agonist, 2 to 4 puffs every 20 minutes in the first hour to see if you can get in the green zone. And if you fail to do that, and if you still remain in the yellow zone, then you have to have a backup plan. A backup plan continuing to use your short-acting inhaler, or as alternative, you can do a nebulizer treatment with the same ingredient, albuterol, and then taking oral prednisone or steroids daily for the next few days. You must have a prescription on hand from your provider so you're able to act right away. Once you've made attempts to stabilize yourself while you're in the yellow zone, you must call for help. You must reach out to your physician or go to a local clinic to make sure your oxygen saturations are stable, you're doing okay with your current regimen, and have received appropriate anticipatory guidelines in order to prevent from going into the red zone. Unfortunately, if you transition to the red zone or danger zone, a person could be experiencing extreme dyspnea or very shortness of breath. They fail short-acting inhalers like albuterol, are unable to do any of their usual activities, or symptoms are the same or have gotten worse since you've been in the yellow zone for 24 hours. This correlates to a peak flow reading, which is usually 50% less than your best peak. Again, when you're in the red zone and your peak flow reading is less than 50% of your best peak flow reading, you're in grave danger of going into acute respiratory failure. You must act quickly. Use your short-acting beta agonist inhaler, which is albuterol, Take 4 puffs. Take any prednisone you may have at home. Call 911 or call your physician. Seek medical attention right away. Being on top of your asthma care involves having a plan, identifying your triggers, knowing what affects your asthma. Is it exercise? Is it pollens? Is it cold wind? Or do you have secondhand tobacco exposure? Be prepared. Use a rescue inhaler when needed. Have it on hand all the time. Some preventive strategies may include treatments with immunotherapy to desensitize yourself from the allergen, avoiding outdoor activities during a season when your pollen counts are high, or wearing a face mask in public settings when there's an infection outbreak, correlating your peak flow with an asthma action plan. Doctors with internal medicine, pulmonology, or allergy and immunology backgrounds can help you manage your asthma. Always stay in touch with your physician, come up with an asthma action plan, discuss preventive strategies. Know that there are treatments available, and asthma is a reversible condition and can be well maintained over your lifetime.